Thanks so much. And I'm very excited to be able to do this. I have a real passion around kidney disease that's sort of grown over the past few years. I really didn't feel like I learned much about kidney disease in school and didn't really know what to do in practice, but this whole idea of estimated GFR started to come into play, I don't know, a few years ago was when I became aware of it, and suddenly it seemed like there were a lot of people who had chronic kidney disease, and it led me to say, what's going on here? And so I really started researching it and was pretty interested in what I found, and I think it's something really useful for our patients. So I'm going to do my best to explain what chronic kidney disease is and what we can do about it. So we'll start off by trying to get a little clearer on the lay of the land. And of course, we have to remember that the kidney has many functions, and we're very familiar with the filtration functions shown on the left side of the slide here. But of course, also it is crucial in regulation of electrolytes and therefore water, and that affects the whole body. It is very important to remember that the kidneys are ultimately the main regulators of blood pressure. And this is a whole other talk about sort of the renal origins of hypertension, but certainly we see it illustrated as chronic kidney disease progresses, that hypertension becomes a part of the problem. But in many patients, chronic hypertension also causes chronic kidney disease. So that's a real conundrum. And then, of course, we have the endocrine functions of the kidneys, including, of course, production of erythropoietin, which is necessary to make our blood, and the final activation step of calcitriol, or vitamin D, which is, of course, crucial for bone health, among other things. So all of these functions start to decline over time as chronic kidney disease happens, or what I'm also going to call chronic renal failure, or CRF in the slides. It used to be pretty universally called chronic renal failure, which was honestly, I feel like, a much clearer description. Chronic kidney disease is so vague and general, it sounds like it could be anything, but it's not. It is specific to basically this loss of nephrons over time and the clinical syndrome that results. And I will say more about distinguishing some of the confusing terminology related to chronic kidney disease, and we'll talk more about that in the third session on glomerulonephritis as well. So anyway, as this slide highlights and makes sense, that the main ultimate treatment as chronic renal failure gets out of control is dialysis, but that really only affects the filtration and electrolyte regulation functions. It really does absolutely nothing to replace the endocrine functions of the kidney. So those essentially have to be given as separate medications. And of course, we have the ongoing problem that dialysis is intermittent, but kidney function is constant normally. So these are really not ideal. And I'm not anti-dialysis. Dialysis is life-saving for many people. It's an amazing therapy. But it also is very frustrating because so many patients are told, well, we don't know what's happening. We'll just wait until it gets so bad you need dialysis. And I feel like there's enormous therapeutic potential that's lost because of that. And I understand some patients don't want to change or won't change, but I feel like they should certainly be given the options. So we'll be looking at a lot of other options to prevent getting to this point. And at each step of the way, we'll be looking at which of these functions are affected, how bad they are, etc. The blue here, I should point out, are things that are basically monitored in terms of tests to see how these various areas are being affected. So, of course, we're very familiar now with, over on the left, BUN, serum creatinine is SCR, and some people use serum cystatin C, which is an alternative to creatinine. My read of the literature is that really doesn't offer any particular great benefit over creatinine, so it relatively doesn't matter that much. Of course, we also have to monitor serum potassium, very importantly. That's actually one of the most important ones, because if that starts to go up, it becomes a risk for sudden cardiac death. And is really one of the main reasons for initiation of dialysis. And really, I should have added EGFR and creatinine clearance for the nitrogen issue here, which I'll talk about a bit later. And then, of course, we have these various measures of the efficacy of erythropoietin and levels of calcitriol. So all these will be coming into play as we go through. So chronic kidney disease is partly so common because it has very common causes. So definitely throughout the developed world, diabetes and hypertension make up the vast majority of cases of why it happens. And these data are from 2007. Glomerulonephritis, when you most sources give it higher, a little higher at about 10%. Cystic disease would primarily be polycystic kidney disease. And then we just have some other random things. But obviously, we can both prevent and treat diabetes and hypertension. And there's much else we can do for a lot of these other conditions as well. So the idea that we should just sit around and wait until patients progress to the point they need dialysis is not true, that there's many other things we can do, even well recognized within conventional medicine to deal with the causes. So one of my main take-home messages from this talk is when someone has chronic kidney disease, to ask why and to go after those causes, especially early on, because there's nothing specific you need to do for the kidneys early on. If you just remove the cause, you can fix the problem. As kidney disease progresses, it becomes harder and harder to do that. So why wait?